So I'm going to talk about what we know for sure about schizophrenia. And the reason for this talk, the motivation for this talk, is that there is now a lot of stuff that we know for sure and about schizophrenia in terms of genetics, other causes, manifestations on brain imaging, and treatment. But sometimes you'll hear people say, oh, schizophrenia is an enigma. It remains as enigmatic as ever, and that is just rubbish. So partly I'm doing this so that we as psychiatrists can know what we know about schizophrenia, communicate that with our patients and their relatives, but also in the media to take on the anti-psychiatrists that are out there. And I'm not going to talk about everything we know for sure of schizophrenia, because there's a hell of a lot of stuff. I'm just going to talk about those things that we know particularly well and that build towards an integrated biological, psychological, and social model. So the biopsychosocial model was first developed, I guess you could say, by an American psychiatrist called George Engel. And he wrote a series of papers in prominent journals like Science in the 1970s. And he was proposing this biopsychosocial model not just for psychiatry, but for the whole of medicine. And in this paper in Science, he talked about atoms building up to molecules, organelles, cells, tissues, and so on and so forth, up to the brain and into the mind, the person. This thing isn't working brilliantly. Is that showing on the screen? No. Could we get a better pointer if possible, or a new battery maybe? We could try this one. Will that work? You have a better pointer? Anyway, I'll carry on without it for the time being. This is kind of working here, but it doesn't seem to work on the screen. It works there. Maybe I need to move. Maybe if I come here. Maybe the battery's weak. Disappearing. Maybe it's that slide. Maybe it's that slide. Thank you. We'll push on anyway. So the point about the biopsychosocial model is that it goes into two-person relationships, family, community, and society at large. And a more modern-day way of illustrating this is in the next diagram, which talks about molecules, synapses, neurons, circuits, and so on up to the whole brain system. And so I'm going to try and present data that builds at these levels about what we know for sure about schizophrenia. And this biopsychosocial model has recently been philosophically justified by Derek Bolton and Grant Gillett. The biopsychosocial model has been criticized for both being dualistic and reductionistic, and which are incompatible. You can't be both. And so this nice little volume by Gillett and Bolton kind of puts the biopsychosocial model in contemporary neurophilosophical perspective. So I'm going to cover these topics: how we know anything at all, a bit about schizophrenia as a concept, the genetic causes that we know for sure are identified, and environmental risk factors, imaging. We're going to talk about some key findings that relate imaging appearances in schizophrenia to the symptoms of the disorder. And I am then going to offer you a solution to the brain-mind problem as well, something that's defeated philosophers for about 2,000 years, It's not my work, it's the work of people working on Bayesian brain and processing. And then, as long as there's time, treatment effectiveness and a bit about stigma as well. So how do we know anything in medicine? And in particular, how do we know something for sure? So Austin Bradford Hill was an English epidemiologist who wrote a famous paper in 1965 about the criteria for knowing whether something causes something or not. And he talked about the strength of the association, the consistency of that across studies, the temporality in whether something came before, whether a cause preceded an outcome, the biological gradient or the dose-response relationship, plausibility, specificity, and experimental design. And of course, Bradford Hill was one of the key developers of the randomization in randomized controlled trials. And so the only thing we know for sure in terms of causation in medicine is when a randomized controlled trial of a treatment has a later effect. This stuff by Bradford Hill is really criteria for an association. But now that we have, in addition to randomized controlled trials, now that we have genetics, known genetics for schizophrenia, we can perform analyses called Mendelian randomization, which can show for sure whether a particular gene or set of genes causes a particular outcome or phenotype. And then the other thing I want you to bear in mind as we go through studies that I'm going to show you, I'm going to draw the key points out from the slides, is that the strength of an association varies quite a lot. Have we got another pointer? So the strength of an association can vary quite a lot. Oh, that's much better, thank you. And the size of an effect is a critical determinant when you're looking at a study for how many people you need in a study to be able to show that effect truly is there. So there are, in general, psychiatry in particular is bedeviled by too many small studies that don't have actually enough power to test the hypotheses that they're trying to test. And so as a rough rule of thumb, if you take a standard measure of the effect size, like D, or Hedges G is another one, but they're basically the same, a large effect of around about 0.7, 0.8, you can get away with only a few tens of patients and controls in your study. And so I'm going to show you PET studies, for example, that are adequately powered when they only have 10 or 15 or 20 patients. But for structural MRI in schizophrenia, where the effect size is more like 0.3, 0.4, 0.5, you need hundreds of patients and controls to adequately detect whether an association or a difference exists. And then for something like, for a very small effect, like a brain-behavior relationship, I'm going to show you data that correlates structural MRI to delusions and hallucinations. To actually know that that association really exists, you need thousands of patients. And so one of the key messages from this talk, I think, is we need adequately powered studies before we know that there is an association or not. And then we need to apply these criteria to know whether that association is a causal relationship. Anyway, I'll try and bring that out as we go through the talk. I'm very happy to take questions as we go along, by the way, but don't feel you have to. So something about the concept of schizophrenia. Schizophrenia was first described probably recognizably by Emil Kraepelin, and the term was first used by Eugene Bleuler, just like Parkinson's disease was first described by James Parkinson, and Huntington's chorea was just described by Huntington. And that is a clinical syndrome. It has some face validity as a concept because we see patients with these features often together. Now, DSM and ICD, nope, sorry, wrong thing. DSM and ICD have codified this concept into diagnostic criteria, and the purpose of this has been to generate a very reliable concept of schizophrenia, so that when I talk about schizophrenia, what you think about schizophrenia is likely to be a similar thing. And there are now lots of studies showing that this concept has reliability and validity, contrary to what some people might say. So, for example, this is a systematic review here. We've got the same problem if I picked up the wrong one. This is a systematic review here of test reliability studies for the major psychotic disorders, schizophrenia, bipolar disorder, and unipolar depression. And there is, they had 48 studies of schizoaffective disorder, 42 of schizophrenia, 33 of bipolar disorder, and 35 of unipolar depression. And this is showing the kappa statistic for these studies, for this diagnosis, in terms of test-retest reliability. I could show you a very similar graph for inter-rater reliability, but I just chose this one. And the point is that this kappa statistic controls for chance agreement. So if you only have 2 or 3 diagnoses, you're going to get lots of people agreeing by chance. So this kappa statistic controls for that. And roughly speaking, a kappa value of around about 0.5 is moderate agreement, 0.6 and above is substantial agreement. So we see here that in these studies, the inter-rater reliability is high. It's about 0.7 or 0.8. It's lower for schizoaffective disorder. And those are very respectable values. They compare, for example, to other medical tests' reliability. So signs like abnormal pulses or signs of obstructive airways disease, the kappa values for inter-rater reliability or in test-retest reliability are a bit lower. So our diagnoses in medicine, in psychiatry, provided we use diagnostic criteria, are more reliable than some of the signs in medicine, and they're even as reliable or more reliable than things that are supposedly objective, like an X-ray of the hand to detect osteoarthritis. People think, oh well, an X-ray shows osteoarthritis, doesn't it? Well, actually, radiologists and doctors will often disagree whether an X-ray does show signs of osteoarthritis or not. And if you ask surgeons whether the site they've operated on has become infected, they will agree even less, particularly if it's them done the operation. And one of the good things about ICD-11 is that these inter-relator and test-retest reliability statistics are going to be even higher still, based on field trials. So we have a reliable diagnostic concept of schizophrenia. And we know quite a lot about what causes it, and we'll start with the genetics and build up. So this is a meta-analysis of 41,000 people. This is a massive study. We can be pretty sure what it finds is true. It's a fact. And what they found is that there's around about 8 copy number variations that increase the risk of schizophrenia, sometimes as high as 50 times. And there's a list of the copy number variations along there. The common one is 22q11.2. So a copy number variation is having an extra copy or one less copy of a gene. And at 22q11.2, the copy number variation there that is associated with schizophrenia is sometimes known as velocardiofacial syndrome or de Jour syndrome. It's quite common. So probably a fairly conservative estimate is that about 2 or 3% of our patients with schizophrenia have copy number variations that is causally implicated in schizophrenia, in causing their schizophrenia. And the clinical importance of that is that if you don't detect it, you might not detect the associated physical, sometimes congenital malformations that accompany it. So, for example, in velocardiofacial syndrome, people often have congenital heart disease. And undetected copy number variations may be a reason, for example, for sudden cardiac death in some patients with schizophrenia. And in some populations with prominent neurodevelopmental schizophrenia, so if people have both learning disability and schizophrenia, for example, like an IQ of 85 or lower and schizophrenia, there's probably about 15% of them have a copy number variation underlying their condition. Now, this is not affecting that many of our patients, but these commoner genes of smaller effect are probably affecting most of our patients. So this is a famous figure. It's a Manhattan plot, because it looks a bit like the skyline of Manhattan. and these are all 23 human chromosomes along the bottom. And you can see all these bits here above this red line are statistically significant according to standardized statistical criteria in genetics. So in this famous study published in Nature in 2014, of more than 100,000 patients and controls, there were 108 genome-wide significant loci across the human chromosome that are associated with schizophrenia. And because this is such a massive study, this is basically a fact. This is 100,000 patients and controls. This group have gone on to publish 2 or 3 more analyses. The genes include glutamate genes, and the most recent paper from the Schizophrenia Working Group of the Psychiatric Genomics Consortium has found 287 genomic hits that are associated with the subsequent development of schizophrenia. And all these ones that were found in 2014 have held up in subsequent analyses. And the genes generally are involved in neurodevelopment and synaptic plasticity. And you can add, for any individual patient, or indeed for anyone here, you could take your blood, see whether you've got any of these risk genes, multiply them by the odds ratio associated with them, and come up with a polygenic risk score for one's liability to schizophrenia. Now that is not clinically relevant yet. It's not a diagnostic test, I should stress to add, but it's a good measure of your risk. So those in the top 10% of polygenic risk scores for schizophrenia have a 16 times increased risk of schizophrenia compared to those in the bottom 10% of polygenic risk scores. Yes, good question. Fire away. Do you have a microphone? There's a lady who wants to ask a question. Over there.
I'm going to ask in Turkish. You hear me? Can you hear me? Sir, can you hear me?
Yes, I can, thank you.
Okay. Thank you very much for the very nice presentation. In the older times, when we said cancer, it equaled death. People couldn't even use that word. For instance, breast cancer. So if you can diagnose it early, then you can completely treat it. Fine. So early diagnosis is very important. So instead of these genetical tests here, perhaps maybe we shall focus on early diagnosis work, because then we will have the upper hand, won't we, if we can diagnose earlier. I do not know about what you're doing in your country. What is being done in your country, indeed?
So, did everyone hear that question? I'm not hearing my own voice, so that's pretty unpleasant. So, the question is about early intervention in psychosis or schizophrenia. Genetics could play a part in that, in terms of finding genes that are dramatically increasing the risk. As I'll talk later, brain imaging definitely could have a role in the early detection of schizophrenia in particular. And I would agree with you, yes, early intervention in most conditions across the whole of medicine is highly desirable. We in Scotland, in Edinburgh where I work, we don't actually have an early intervention service. They do in England. The health system in Scotland doesn't see it as enough of a priority to fund an early intervention service. And I suppose my concern about early intervention services is that very often they take a lot of funding and the best staff away from general psychiatric services. And so I'm currently working on a project in Malawi, for example, in Africa, where there are 3 psychiatrists for 20 million people. And we're not going to be setting up an early intervention service, we're going to be setting up a service. So, and in the NHS in the UK, the funding is not great, and I still think the service is still not as good as it could be in general. So whilst in an ideal world, we would have enough funding for early intervention services for psychosis everywhere. I think it's only in the wealthiest countries where that's probably a cost-effective way of spending money.
Many thanks for your talk. I wonder if these liability genes also play a role in another illness. Has there any comparison about this?
Yes, they do. It's a good question. So these genes for schizophrenia are the strongest known genetic risk markers for bipolar disorder. So the genes for schizophrenia and bipolar disorder overlap to a large extent. But actually, we kind of knew that before, because a strong family history of schizophrenia is a stronger predictor of bipolar disorder than a strong family history of bipolar disorder. So to some extent, these are genes that index abnormal neurodevelopment and synaptic plasticity that increase the range of a whole range of psychiatric disorders. Yes, some genes are specific, but most genes are increased risk for a whole range of different disorders. You're quite right. Which is another good reason why we can't use this as a simple diagnostic test. You know, psychiatry is not that simple, and schizophrenia is definitely not that simple. But we do now have a whole bunch of genes that we know for sure increase the risk of schizophrenia and bipolar disorder and other conditions, including the good old dopamine D2 gene, which we'll come back to dopamine in a minute. I think we'll skip that one. So one of the values of this polygenic risk score is that you can relate it to things like brain imaging. And this is work done in 2,864 structural MRI scans in UK Biobank. UK Biobank is a study of 500,000 healthy people, or people over the age of 45, who were healthy at the start, and will eventually have 100,000 brain and body scans. And so it's a marvelous resource. It's not so great for psychosis because very few people have psychosis. There's about 1,000 people in total out of the 500,000 with any psychotic disorder. But what you can do, for example, here is show that the polygenic risk score for schizophrenia reduces, or is the average global cortical thickness, or the average global cortical volume. So we have a link here between the genetic risk factors for schizophrenia and reduced brain volume that we also know is present in patients with schizophrenia, and to some extent those at risk. And others have taken this work forward. There's a very nice paper from Stauffer and colleagues this year, in 29,000 UK Biobank participants, which also shows, using this technique of Mendelian randomization, that the genes that increase the risk of schizophrenia directly cause reduced grey matter volume in the thalamus. So not only is this an association, it's a causal link in at least some parts of the brain. Moving on to environmental risk factors, there's a meta-synthesis of umbrella reviews by Chelsea Arengo et al. In the World Psychiatry last year, looking at what we pretty much know for sure from epidemiology in terms of the causes here of schizophrenia, but in the article they also cover bipolar disorder and depression and anxiety. And this is not new, you'll know most of this stuff, but we basically know with convincing evidence, we pretty much know for sure that things like the clinical high-risk state and being an immigrant in England in particular, but in other countries as well, increases the risk of schizophrenia by about 3 or 4 times. And we know that because there are more than 1,000 people in these studies, the p-value is massive, and there's very little heterogeneity across the different studies that have looked at that. And there is, according to this standardized nomenclature across the whole of medicine, there is highly suggestive evidence for these causes of schizophrenia, including our old friend cannabis use, which roughly increases the risk 4 times, stressful events 3 times, and a range of childhood adversities increasing the risk of schizophrenia 3 times. I think the translator's caught up. So again, none of these causes are specific either. So actually migration and this clinical high-risk state are relatively specific for schizophrenia, but cannabis increases the risk of psychoses generally, depression and anxiety, and so do these problems. So it's probably the combination of the risk genes for schizophrenia and these environmental risk factors that determines whether you get schizophrenia, bipolar disorder, depression. Question, fire away.
Yeah. I wonder whether all these risk factors come in a package, because being a Black Caribbean ethnicity might increase your cannabis use and stressful events and childhood adversities. I mean, these all might have some cumulative effect. I mean, they may come as a package. What would be your comment on that?
Yes, you're right. Here's my comment on that. So they could, very often they do. You do see people from a disadvantaged background who are associated with some kind of abuse or trauma in childhood, who then end up in care or being bullied, maybe take up drug use from an early age. So very often these risks are associated. Sometimes they're not. So sometimes they can be enough on their own, but very often they can come together. And presumably, a bit like if you've got a lot of the genetic risk factors for schizophrenia, you might get a relatively pure genetic schizophrenia, let's say, or a copy number variation, you might get a relatively pure CNV schizophrenia. Similarly, you can get sometimes, we all see drug-induced psychoses, which seem to be relatively pure drug-induced psychoses, sometimes which go on to full-blown schizophrenia. So, yeah, the causation of psychosis is multifactorial. And ultimately, if you were going to try and predict it, you would probably want to have a prediction algorithm that included a range of genetic and environmental risk factors and maybe something like brain imaging as well. Oh, here we go, brain imaging. So I've mentioned some of this already, and I'm not going to dwell on it. It's a slightly busy slide, but I did a whole talk about neuroimaging yesterday. So this is good old hand-traced region of interest structural MRI. And we reviewed that literature, as did Ian Wright, a long time ago. And you find in about 40 studies of a couple of thousand patients and healthy controls. So these are pretty much reliable facts. There's roughly speaking a 3% reduction in whole brain volume and a 5% reduction in the medial temporal lobes, particularly the amygdala and hippocampus. And that's been shown again with another technique called voxel-based morphometry, and now more recently with a technique called free suffer. So systematic reviews and mega reviews of these literatures have also shown pretty much the same findings in terms of a neuroanatomy of schizophrenia, if you like. Good, we're up to date. Now what you find in this clinical high-risk state is similar but much milder effects. So the effect size here is about 0.1, a small effect. And you contrast that with an effect size of around about 0.5 in patients. That strongly implies that there are changes in the loss of grey matter in the brain between being at high risk and actually having the illness. And there are about 5 studies, I think, including one of ours, that does show such changes over time. But those effects are small. The D measure of effect size is about 0.2 and 0.3, and it's only been shown in about 100 patients. So I don't think that qualifies as a fact by my own definition, because it hasn't been shown in enough studies in enough people as yet. But it's highly likely to be the case. And moreover, we got this brain behavior link. So the superior temporal gyrus has been associated with positive symptoms, particularly hallucinations, in very many studies. In hand-traced region of interest studies, in voxel-based morphometry studies, and in more recent studies using free suffer. And these are the review articles of those different technologies, finding this convincing association between the size of your superior temporal gyrus, particularly on the left side, which is where your auditory association cortex is, funnily enough. So having less grey matter in your auditory association cortex is associated with auditory hallucinations, a link between brain and behavior. And these findings have also been validated in post-mortem studies. So these are systematic reviews of post-mortem brain studies showing a 2% weight reduction, very similar to the 2 or 3% volume reduction you see in live patients, with an effect size in the hippocampus of about 0.5, almost identical to the effect size that you see in patients with schizophrenia in the scanner. So, and we know from neuropathology studies that the pathology is not gliosis or inflammation, it's not a loss of grey matter, it's that the brain cells are smaller and less well connected. It's like, which is very much like the neuropathology of stress, actually. And it does raise the question that if these grey matter losses are stress-related, they are potentially, and the brain cells are just there, they're just smaller, shrunken, and less well connected, raises the possibility that we can treat and maybe recover, or at least improve, that synaptic connectivity and plasticity. And indeed, that's probably how some of our treatments work. I'm going to skip that one, and I'm going to skip that one in the interest of time. Now, what else do we know about the chemical pathology of schizophrenia? We know that dopamine is involved. And I've already alluded to this. This is a systematic review of these 15 PET studies, positron emission tomography, in people with schizophrenia. And what each of these studies has done is they administer a radioactive ligand, fluorodopa, which, like all dopa, is made into dopamine in presynaptic nerve cells, particularly in the striatum, particularly in the caudate nucleus of people with schizophrenia. And so you can use a very strong gamma camera to measure the radioactivity in this area, which is indexed by radioactive labeled dopamine. And what you find in all these studies, generally speaking, is an increased synthesis, turnover of dopamine in the brain in patients with schizophrenia. And these studies usually find that, but when you put them all together, the effect size is really quite large. It's about 0.8. So this is basically a fact. Dopamine turnover is increased in people with schizophrenia. We know that for sure. We don't know that that's the primary cause of schizophrenia. It may be that glutamatergic abnormalities underlie this, but there are studies which support the idea that dopamine is very important. So cannabis and amphetamine and other drugs, they increase the risk of psychoses by increasing dopamine turnover and effects in the brain. Cannabinoid antiemetics, which are sometimes used to treat people with cancer, they increase the risk of delusions and hallucinations in people with cancer because they're getting cannabis, effectively. And that's been shown in randomized controlled trials. So we know for sure that cannabinoid antiemetics cause delusions and hallucinations in people with cancer. Supports the idea that cannabis and other drugs increase the risk of schizophrenia by increasing dopamine. So you can put all this that we know, stuff that we know for sure about schizophrenia, you can kind of put together into beginnings of a biopsychosocial model. And this is a cartoon that a brilliant lecturer called Vicky Barker did before she went to become a psychoanalyst in London. And so we know that things like childhood maltreatment and adversity, they cause stress and they sensitize your stress response system. Sometimes directly through endocrine effects and possibly also through genetic methylation effects. And things like migration may also sensitize the stress system in a similar way. There's some evidence to suggest that. We know for sure that I've pointed out that there are brain structural changes and there are increases in dopamine, and it's probably the combination of these at a brain level that is the combination of increased dopamine and reduced grey matter is associated with and probably causes psychosis. So the question is, how does those effects at the brain level cause the symptoms and the experiences of psychosis. And so I am going to turn to this. Now, this is more of a model of consciousness and cognitive processing than a known fact about schizophrenia. But I put it in here because it's the best current model I'm aware of for going from the brain to the mind, from going from reduced grey matter and increased dopamine to delusions and hallucinations. You know, how does that work? And in essence, what is probably happening is that the dopamine is making you more attendant to irrelevant stimuli and less attendant to relevant stimuli. And the cortical thickness reductions are making you less able to benefit from memory of experiences in the past. And this is put together in a Bayesian or predictive coding account of psychosis. And to put it simply, a loss in the precision or the effects of experience, prior beliefs, make people more likely to hallucinate. So, for example, this is a very simple visual illusion of a Charlie Chaplin face. This is Charlie Chaplin's convex face. That is, we know that is concave because it's the inside of a convex face, but our brains still tell us it's a face, like it's convex, it's a visual illusion. Now, people with schizophrenia are less subject to visual illusions in general. And one compelling explanation for that is that their perception is less influenced by their previous experience. So they are more open to the effects of dopamine altering their perception and experience, and they are less able to use memory, partly because of stress and genetic impairments and loss of grey matter, to actually overcome perceptual ambiguities. So they are less likely to be able to benefit from previous experience. So, for example, they might see something a bit weird, like that lady's waving at me in the box. No, she's not. Maybe she's just translating. But someone with schizophrenia might say, she's like looking at me. Maybe she's talking about me. I don't know. I've been here before because I've had this kind of experience. But someone might not have, or with less experience of this kind of experience, you can roughly, hopefully, see what I mean. So that's how we might get from increased dopamine and reduced cortical thickness to psychosis experiences. So what about treatment or management? Let's move on to that. I think we've got about 15, 20 minutes left. Or maybe slightly longer. So one of the problems with the word schizophrenia is that psychiatrists like us tend to think that it's got a bad prognosis, and sometimes it does. But it's not as bad as we tend to think. It's certainly not a progressive illness that results in inevitable decline. Our experience of people with schizophrenia is biased towards those with chronic schizophrenia who need ongoing treatment. But there's about 50% of people with schizophrenia that do well after a diagnosis that we never see because they're looked after by GPs or they're not looked after at all. And so I think we as psychiatrists need to appreciate that, roughly speaking, 50% of people who ever get a diagnosis of schizophrenia will have a good outcome, either in terms of symptomatic response to treatment, not needing treatment, getting a job, in a relationship, having a family even. And of course, part of the way to get people outcome improved is to use antipsychotic drugs. Now, antipsychotic drugs, as I am about to show you, are some of the most potent treatments in the whole of medicine. So there's a systematic review of 17 studies with more than 3,000 participants that finds that 80% of first episode patients get at least 20% better on the PANSS, 50% get at least 50% better on the BPRS. Substantial symptom reductions. And we've all seen, I guess, patients with a first episode psychosis, you give them that first pill, and they show almost an immediate response, and they certainly show a dramatic response within a week or two. That's my experience clinically. Now, the drug effects are less good in acute relapses, but in this systematic review done by Stefan Leucht of 29,000, almost 30,000 patients, you get fairly substantial symptom reductions according to the PANSS or the BPRS. And if you have responded to an antipsychotic drug and you carry on taking it, well, this is this top line here. This is another systematic review of maintenance trials published in The Lancet in 2012. If you taking that drug, your relapse risk is about 27%, whereas if you stop the drug once you've responded, you're more likely to relapse than not. And this has been shown in 24 randomized controlled trials in a grand total of 1,465 patients randomized to stay on the drug and 1,204 patients randomized to change to placebo. So you need to, that's a massive 64% to 27% reduction in the risk of relapse, a 37% absolute reduction in risk of relapse. And I use these figures with my patients all the time, and I think it actually helps maintain compliance. So you can translate that 37% into a number needed to treat, and it's around about 3. So you need to treat 3 patients, you need to keep 3 patients with schizophrenia on an antipsychotic drug once they've responded, for 1 to not relapse that might have done otherwise. And that is about as strong a treatment as effect as you will see anywhere in medicine. If you tell neurologists and cardiologists, we've got an NNT of 3 for antipsychotic drug maintenance, they will fall off their seats. I mean, does anyone know, so what's the number needed to treat for, say, aspirin after a TIA to reduce the risk of stroke? Anyone know what the NNT is? Have a guess. Somebody shout out a number between 0 and infinity. 10? Higher? 100. Pretty much. So you need to treat 100 people with aspirin after a TIA to reduce the chance of one of them having a stroke. So this is way more potent than most of the treatments in medicine, and yet still we psychiatrists are a bit apologetic about our treatments. So continuing antipsychotic medication has a range of other benefits. Obviously it reduces relapse, it reduces admissions to hospital, it reduces violence and aggressive behavior, and actually it probably reduces death as well. It has side effects, obviously, like sedation and weight gain and movement disorders, but overall these are very effective treatments. And I think we should know that and be quite proud of it. So this is all the data that was published in a recent systematic review about the effects of antipsychotic drugs saving lives. And these are all the drugs that have been shown in all the studies to reduce the mortality in schizophrenia. So sometimes you will hear people say, oh, antipsychotic drugs, they may work, but they kill patients, or they increase their weight and their adverse metabolic profile and increase the risk of heart attacks and strokes. Well, maybe they do slightly, but overall, they certainly reduce the death rate in schizophrenia. And these effects have been shown not just in westernized countries, but they've also been shown in places like China and Ethiopia and other low and middle income countries. So antipsychotic drugs save lives, as well as reducing relapse with a very massive effect. And so to ram home this message, if you like, this is another systematic review of Stefan Leucht's work, but here he's comparing general medicine drugs and their effects on the left in grey with psychiatric medications on the right. And you can see here that overall, the average effect for psychiatric drugs is 0.35, and the average effect size in medicine drugs is 0.34. Result for psychiatry. That's not a significant difference, by the way. But on average, our medicines in psychiatry are about as effective or ineffective, if you like, as in the rest of medicine. There are some outliers. So this is interferon for MS. and there is treatments for hepatitis C. But you can see that there's also a bunch of treatments in medicine that do more harm than good. So this is the effect size for maintaining lithium in bipolar who've responded to it, an effect size, a large effect size of about 0.8, and we also know that lithium reduces overall mortality and suicide. These are the effects for maintaining antipsychotics and antidepressants once you've responded. These are the effects for acute treatment. Anyone want to guess what this is? It's CBT as an acute treatment for depression. And this is ECT versus sham ECT. It's the most potent treatment in psychiatry. And it's way better than just about everything else in medicine, by the way. So one of my colleagues, who is also one of my patients, is currently undergoing ECT in Edinburgh. She's very open about it because she's had a relapse of her psychotic depressive illness. Anyway, she will get better soon. Now, I've talked about a biopsychosocial model, and I don't want to give the impression that I just think we should treat schizophrenia with drugs. Quite the reverse. Certainly in Malawi, I hope we'll be using education and support. And so, not only do we have very potent drugs in schizophrenia, we have very potent psychosocial interventions. So these are all systematic reviews done in the Cochrane Library. Does everyone know Archie Cochrane? He was Scottish, would you believe, and wrote very bad poetry. But he was a very good epidemiologist. And so the Cochrane database of systematic reviews is systematic evidence gathering for all the interventions in the whole of medicine. And these are stuff that I've extracted for psychosocial interventions in schizophrenia. So illness education, educating patients and their relatives and carers about the illness, reduces relapse and increases medication compliance, with numbers needed to treat of around about 6 to 12. And we know that's a fact because it's been shown in 44 randomized controlled trials in more than 5,000 patients. So if you're not giving your patients and carers illness education for schizophrenia, you're missing a very effective treatment in terms of reducing relapse. Similarly, family interventions have similar effects. They're more difficult to do, and probably illness education is an easier way to change, to have the same effect. Something called individualized placement and support, have people heard of that? Has now been shown in 14 randomized controlled trials of more than 2,000 patients to get people with schizophrenia back to work or into work in about 50% of cases. Now, some of that's voluntary work, some of that's part-time work, some of it's paid work. But 50% of people with schizophrenia with adequate support can get a job. And that is a massive boon for people's self-esteem, for their activity levels, for their social integration, and to reduce stigma, both for them and the rest of society. The data for cognitive behavior therapy and metacognitive training is less impressive on Cochrane, and social and life skills training may reduce negative symptoms. Now, these Cochrane reviews are a little bit old, and again, Stefan Leucht's group have shown in recent systematic reviews in Lancet Psychiatry, in thousands of patients, that family interventions, family education, CBT are all effective ways of reducing relapse in schizophrenia. Most of these studies are done on top of drugs. So drugs have an effect, psychosocial interventions have an effect. You put them together, you get the best of both worlds. So if you go back to here, might indulge myself a little bit more, not only do we have drugs that are on average about as good or better as in the rest of medicine, you start adding in our psychosocial interventions, they're even better. So we as psychiatrists should be proud about the treatments we can offer our patients for schizophrenia, at least. Okay, so I wanted to talk about the social aspect of the illness, and to my mind and that of Norman Sartorius, who's a bit of a hero of mine, stigma is the main obstacle towards progress in the field of mental health. And certainly, if you speak to your patients and their family members, Stigmatization is alive and kicking and affecting their lives. And so there recently was a very good overview of stigma in schizophrenia, published in The Lancet just about a month ago. And they did an umbrella review of 216 systematic reviews of the literature on stigma in schizophrenia. And the thing that works above all is getting people to meet people with schizophrenia. And they find out that, hey, they're actually very nice people, sometimes nicer and more sensitive than average people, who are dealing with the problems of an illness as well as all the other problems that people encounter in their lives, and deserve your respect and admiration. And they're not axe-wielding maniacs who are about to kill you or people you know or love. So illness education has a bit of an effect on reducing stigma, but meeting people with schizophrenia is even more effective. And I encourage, quite a few of my patients are now writing accounts of their illness to try and reduce the stigmatization of the condition. And I'll miss that one out. And indeed, I've published a book with a journalist who has schizophrenia. We called it The Beginner's Guide to Sanity. And it's had 14 ratings on Amazon, 4.5 stars, not too bad. And it's had 2 good reviews in the Lancet Psychiatry and the British Journal of Psychiatry by these people with schizophrenia. So these are service users who were amazed how informative the little book is, and even thought it was illuminating. So Erica Crompton is a journalist who's very open about the fact she has schizophrenia. Clearly she's still able to write, but she has taken her about 15 years to realize that antipsychotic medication is her friend. And she spent about 10 missing years in America, which she's quite open about. There is not as yet a Turkish translation. Maybe somebody would like to do it. Maybe not. So, I want to stop, and I would like to think I have persuaded you that we know quite a lot about the causes and treatment of schizophrenia, that the concept has diagnostic validity, it's got some predictive validity, and biological validity it certainly has. We know that there are now 250 risk genes that increase the risk of schizophrenia. There are more than 10 copy number variations and other genes of large effect that are associated with an increased risk of schizophrenia. We know that the genetic and environmental causes of schizophrenia mediate their effects through the brain/mind in terms of dopamine and reduced cortical thickness. And in particular, subcortical dopamine excess may increase salience of sensation, may increase one's attention to irrelevant stimuli and reduce one's attention to relevant stimuli. And that the reduced cortical size may reduce what David Helmsley called the past regularities of experience. I particularly like that phrase. So our memory becomes, or people with schizophrenia, or people high on drugs, their memory becomes less reliable. And their perception, being less reliable, is less able to be constrained by their memory and experience. We know that antipsychotic drugs potently reduce the symptoms of schizophrenia. They are very effective at reducing relapse, and actually, we psychiatrists save lives with our antipsychotic drugs. Outcomes are best, surprisingly enough, when drug and talking treatments are combined in integrated services, and that stigma remains arguably the biggest foe of both us and our patients. So, thank you for your attention.